distinguished chairpersons, endless delegates, my dear Sindhu Madam, Venu Sir, Agustino, Shabir Ali, and all my friends. Let's begin in time because we don't...
Yeah, we'll discuss. Yeah.
Thank you. And the topic for today is vessel preservation in Kimura pancreatectomy, was given by Ramesh Sir. And thanks to the vibrant, brilliant organizing team in Trivandrum, as well as across the globe of the alumni, the surgical gastro alumni of Government Medical College Trivandrum. You know, paying tributes is very emotional. The maverick who pulled the trailer on his shoulder when he was alone, Professor N. Rajan, thanks to Sir and all his guidance. And the 5 stars, we call it a 5-star, they who actually followed his path as successors, Professor Arunkumar, Matthew Koshi Sir, Jubilee Sir, Virula Sir, and Boni Sir. You learn from your PG colleagues. That is a total difference. I mean, in GS surgery, you learn from your final year PG, second year PG. When you become a final year PG, from the first year PG also you learn. From the juniors also is learned. Actually, all these gentlemen were my seniors, especially my thanks to Ramesh Rajan Sir for his thought of having this 50th year meeting here in Trivandrum. So, let's go back to the actual topic. See, the posterior dissection plane below the body and tail of pancreas is beautifully described by Kimura in his seminar article. And this is the inferior vena cava, this is the aorta, and this is the fusion plane of treats, which is posterior to the head of the pancreas, and this is the fusion fascia of toll, which is below the body and tail of pancreas. This is an embryological fusion plane we utilize in so many surgeries, be it left hemicolectomy, be it splenectomy, be it distal pancreaticosplenectomy, be it adrenalectomy. Left side, it's a beautiful plane, and if the surgeon is kind enough to listen to the plane, we almost always get there and we can go between the two planes. Sometimes I'm sure most of us must have taken the gerontous fascia also along with. But still it's okay, but there is a beautiful plane, and this is even, Dr. Kimura was in such a fashion that he went on to show it in histology as well. So yesterday Dr. Deepak Verma was talking about laparoscopic dismal pancreatectomy because of the difficulty in getting the planes there. Absolutely, he is true in difficult cases. But the variation of splenic vein with respect to the 360-degree orientation of body and tail of pancreas is so crucial in planning this. The fortunate thing is that you can do the virtual surgery in radiology console before you actually embark on the distal pancreas. So the traditional teaching is splenic artery runs through upper border of pancreas. Splenic vein is actually encased within the pancreas, most often within the body of the pancreas, at the center of the body of the pancreas. Artery at the upper border, body within the substance, we should imagine like that. So this is a beautiful plane separating that fascia from the splenic vein. See, all this, it's almost like, selling gold into goldsmith. We know what is the difference between Kimura and Varsha. I think we should not discuss that. Many comparisons, practically they are same. There is not much difference in morbidity and mortality between a distal pancreaticosplenectomy versus a spleen preserving distal pancreaticosplenectomy. The only thing is that you have a beautiful count, platelet count, normal platelet count at the end of this surgery, whereas it is almost always raised at the end of a splenectomy. See, that is why you give pneumococcal vaccine even if we are planning a spleen preserving distal pancreas. Suppose by chance the splenic vein is getting torn, we have to do a splenectomy, it should be given preoperatively. General surgery, we have plan A, plan B, plan C. According to RR, you have plan Z. If there are more alphabets in English, then you will have more plans. So this is the important thing. Anticipate the worst and plan the best. Just 2 small videos. This is about a solid pseudopapillary tumor. I am not talking about the case selection and all that because it's again such a noble audience. You learn the splenic vein and splenic artery well before CT and try to focus all the branches. This patient had an MR also done from outside. That is why I thought I would show the MR also. But CT is always better. MR, it's a slightly difficult task to identify each and every vessel. So radiologically, it's a solid pseudopapillary tumor, small size. So we don't need much lymphadenectomy. This is our standard left upper quadrant approach in laparoscopy. This is yesterday Dr. Dept sir was telling this. Fine dissection along the inferior border of the pancreas, separating the root of left transverse mesocolon. A good amount of bummalization this area. This is the upper area dissection. The splenic artery is carefully taken along the upper border of the pancreas. It is preserved. Then we come back to the lower area to dissect the splenic vein. And this window is very important. Retroperitoneum, splenic vein, and anterior to splenic vein, you go inside and define the splenic artery and celiac axis there. We may not be able to see all the vessels appropriately, but we know this is a splenic artery, that's a splenic vein. So if possible, try to dissect the splenic artery and splenic vein. There will be some amount of small tributaries bleed, but still, again, staplers we have discussed yesterday. Now, this is an important thing. Once we divide the neck of the pancreas or the body of the pancreas, this is the arteria pancreatica magna. One of the pancreatic splenic artery branches will be very large. Similarly, one vein also will be large. Unfortunately, we don't have fine clips in laparoscopy till. We have only the Liga clip LT300 or 400 like that. So the splenic vein and splenic artery has to be preserved. And you can just see the upper border of spleen is a bit this thing ischemic only because of the short gastrics has been completely taken. This is solid pseudopapillary tumor. I took some emotional time. That is why this is a NET, neuroendocrine tumor. There is not much difference. Again, it's a bit larger tumor. Define all the tributaries. Carefully take it. Some of the tributaries will need clipping. Some maybe bipolar should be good enough. We need to define the splenic artery and splenic vein very well before we actually staple the pancreas. Again, the largest artery, arteria pancreatica magna. So the splenic artery in the upper border is carefully dissected away. Again, defining this plane is important, the retroperitoneum, then the splenic vein, then the pancreas. Staplers as per your unit preference. Not much difference. So to sum up, let me say two slogans. CT dissection prior to any pancreatic resection, but I mean for any GSLD resection, fine dissection is more than fine, coarse dissection is always a curse. My references, the Kimura's paper. Thank you so much.